Good afternoon. My name is Lorelei Thornburg, and I will be presenting on neurologic emergencies in pregnancy. Thank you so much for inviting me to present. I would like to thank the Society and both the Society for Maternal Fetal Medicine and the Ethiopian OBGYN Society for inviting me. I'm sorry I couldn't be there in person. I am away with my family, so thank you again for allowing me to do this remotely. I am going to try to share my screen, so hopefully this will work. So I'm from Rochester, New York, which is just outside of Niagara Falls area in upstate New York. My pronouns are she, her. I have no relevant conflicts related to this talk, although I do have a book on this subject and a software company related to educational software. I believe that untreated neurologic disease is not good for anyone, patient or baby, and no patient should be denied standard therapy because of pregnancy. No medication, therapy, or imaging is as dangerous to the dyad in the long-term effects to a parent and to that dyad as the sequelae of untreated or undertreated neurologic disease. So the guiding principles is that pregnant people and pregnant patients should receive the same evaluation and imaging as non-pregnant patients. And this is just an illustration of the importance of getting the right imaging. Half of the imaging will only give you half of the answer and can lead you to the wrong conclusions. So when I say that pregnant patients should get the same evaluation, this includes both imaging and contrast, thrombolytics and other therapeutics. Neurosurgery and surgery should not be withheld simply because of the pregnant state. And there should not be a delay for fetal evaluation or delivery for the underlying neurologic condition. There should be an attempt to do these simultaneously, but most neurological conditions actually do not result in hemodynamic instability. Immediate and aggressive care should be the goal for all neurologic disease. Neurologic emergencies typically present in pregnancy, similar to non-pregnant individuals. However, pregnant people have a variety of neurologic complaints specific to pregnancy, including, swelling and edema and numbness in their fingers and toes related to that. So it can be difficult to distinguish normal complaints of pregnancy. Most neurologic diseases present with one or two common symptoms, and there's a high amount of overlap because neurologic disease kind of all leads to one common pathway, including headache, paralysis, seizure, altered consciousness, meningeal signs, and focal neurologic deficits. I like the acronym BRAIN for a system-based approach to neurologic disease and pregnancy. And the BRAIN analogy is basics, review, ask, image, and neurology. Excuse me. So when we go through this, B is for basics. Basics means ACLS approach, blood, and blood sugar. And when you think of ABCs or the ACLS approach, the ABCs of, airway, breathing, circulation, it's for neurologic disease, it should be ABC, D, E, F, G, and that should be easy to remember. So ABCs, and don't ever forget the glucose, because hypoglycemia is a major cause of altered neurologic status, as is hyperglycemia. So basic ACLS, protection of the airway if needed, blood electrolyte assessment, blood sugar assessment. So that's why the B is so prominent in there. Medications to stabilize the event, including anti-seizure medications, mannitol, IVIG, etc., as needed. The R in BRAIN is review, and this includes reviewing the events with the family and or the patient, depending on who is available and who is able to answer questions, to review and narrow the differential. And this can include medical and surgical history, what happened leading up to the events, things like trauma or a seizure, or just anything that could help give narrow the differential. A is for ask. When I say ask, I mean ask the question. And this is a question that I think obstetricians can be thoughtful about. We should ask our consulting services, if this person were not pregnant, what would we do for this disease, event, symptom, whatever we're talking about? And the reason this is important is that there's a lot of knee-jerk responses of, we can't do insert whatever therapy is because this person is pregnant, or we can't do this imaging, or we would do this if this was not a pregnant person. And I think it's important that we focus on the disease at hand and not the pregnancy. And so it's important to ask our consultants what they would do with the disease outside of pregnancy. And then that gives us a starting place to review whether that therapy indeed would be safe for the pregnancy at the time, based on the gestational age. I is for imaging. Complete all and any recommended imaging, and this includes endovascular imaging, lumbar punctures, fluoroscopy. Most of these are much lower exposures than people are afraid of, and the risk to the diet, again, is lower than the risk of a neurologically damaged parent or caregiver. Use contrast, including MRI contrast, if needed to evaluate the lesions in question. Use what is needed to evaluate what is in front of you. And do not substitute inadequate or limited imaging due to risk of fetal exposure. Do not avoid CT out of concern for fetal consideration. So example, people say, well, I couldn't get a CT, so I was waiting for an MRI. If you think a patient has a stroke, get a CT. That is the more readily available test. And then N in this acronym is for neuro and neurosurgery. So involve your neurology and neurosurgery teams early and get their help and support to care and get assessment of the patient. Engage these teams and discuss the pregnancy physiology and how this may be changing labs or laboratory results, and help support differences in pregnancy care. And then advocate for that patient to get any and all standard of care regardless of their pregnant state. Okay, so let's go through a few cases where we're going to apply some of these principles. So case one is going to be a headache. So we have a 32-week pregnant person who calls ahead with a headache, started yesterday and nothing is helping. So we're going to want to ask some questions. And some of our key questions here is going to be, is this a new or is this a chronic headache? Is this person a headache sufferer who struggles with migraines? Was this a sudden or thunderclap headache? That should be something that should put up little red flags for us. Was the severity different in a contextual event? And then things we want to really watch for are markedly different characteristics or manifestations, increasing frequency or severity. And if it's accompanied by new or focal neurologic symptoms, those would be something we really need to watch for. And we have to be careful because in maternal fetal medicine and obstetrics, we are easy to jump to the conclusion that every headache is preeclampsia, and there are, in fact, other causes of headache. So in this case, some of the key things we want to ask is, this is a chronic, an acute headache, and then again, that severe versus thunderclap versus sudden. So differential of a headache is absolutely enormous. It ranges from tension headaches to sinus headaches, migraines headaches, pseudotumor. You can get CVT, you can get meningitis, mass lesions. There's the sky's the limit when it comes to headache. But anytime you have a new acute headache after 20 weeks, of course, you have to put preeclampsia in the diagnosis. So in this case, of course, it is preeclampsia, 32 weeks headache, elevated blood pressures, 3+ proteinuria, and she does indeed have help with platelets of 55. She's admitted to your service and gets the standard care for preeclampsia. You begin to move towards delivery because she has this terrible headache with HELLP syndrome. And unfortunately, as you're rounding on her, the headache suddenly worsens and she becomes altered. She's not making sense and begins vomiting. Well, now we're worried that there's something more serious going on in addition to just preeclampsia. So one of the things we want to be thinking about is a secondary event, and in this case, something like a subarachnoid hemorrhage. So this is responsible for 5 to 12% of maternal death. You cannot distinguish what is causing a hemorrhage in the head based on symptoms, but the keys to any blood inside the meninges is going to be a sudden severe headache, nausea, vomiting, and meningeal signs. And then secondary things that should lead you down the path of thinking of blood in the head are focal neurologic deficits, altered consciousness, seizures, and hypertension. When you get that rapid CT, you're going to see blood throughout the cisterns and throughout all the different lines between the hemispheres of the head. And so you can see those all outlined here. And you're going to want to do an LP to make sure this is blood and not meningitis or something else, but you're definitely going to want to do that CT first, unless you want to find out about how to manage a herniation. And again, the ABCs come back into play here. You want to stabilize that patient. Blood pressure reduction is key. You want to manage any cerebral edema. Mannitol is safe, but can cause amniotic fluid shifts. You're going to want to do seizure control and fetal monitoring only if you plan to act on it. There's a wide variety of things that can cause subarachnoid hemorrhage, but uncontrolled hypertension and preeclampsia is one of the highest risk things, and it appears to be related to delays in treatment and the systolic blood pressure. The annual population prevalence is about 18 per 100,000 with a 2% annual rupture risk. These tend to rupture the most in the reproductive years, so these are something we should be watching out for if you're worried about AVM rupture. And these, if you know somebody has one, you should consider treatment before pregnancy if it's more than 5 centimeters. And these tend to rupture a bit earlier in the periviable period, and then a second peak postpartum. Neurosurgery, if you need it, avoid hypotension during the surgery. Endovascular approaches appear to have better outcomes, again, probably because they have smaller bleeds. Delivery mode after repair in surgery is probably going to be cesarean delivery, just based on a fear of Valsalva and pressure on that new repair. But passive descent and operative delivery may be an option. Stable and unruptured vaginal surgical repair before delivery, typically vaginal delivery is safe. Any medication questions that you have in pregnancy, these are the 2 Rochester sites that can help by chat or by phone. Just wanted to point those out. And then just also pointing out that ischemic stroke is known to be increased in people who have both migraines and use OCPs. So be careful of that. Okay, so we're gonna have a patient with altered mental status next. This is a patient who underwent a TOLAC. She's brought in by her partner with pronator drift and slurring words. Postpartum, she had endometritis, but was an otherwise uncomplicated pregnancy. So when you think about altered mental status, you want to think about what might have preceded this. So think what was witnessed as the onset. So think about whether it was preceded by a headache or a seizure or other focal signs that can help narrow the etiology. Drugs, intoxication, anything that can cause a seizure, anything that can cause intracranial hemorrhage, preeclampsia, eclampsia, anything that can cause a stroke, anything that can cause an ischemic stroke can give you altered mental status. Again, that CT is going to be your first line, LP, and MRI if you need it. Ischemic and thrombotic stroke is very rare in pregnancy, thankfully, but it is the second leading cause of death in women overall. And the mortality is as high as 25%, although hemorrhagic is worse than ischemic. Peripartum is the highest risk for ischemic stroke in that first 10 days postpartum, although late second and third trimester account for the remainder of it. Hemorrhagic and ischemic stroke etiologies have significant overlap with AVMs, aneurysms, hypertensive disorders of pregnancy, and preeclampsia can cause either ischemic or hemorrhagic events, depending on what happens with them. And additionally, all of these can both result in an ischemic event that then becomes hemorrhagic as that clot resolves, and a hemorrhagic event that then becomes ischemic as you get a secondary watershed infarct. So you can get a mixed event with almost any stroke event. Risk factors for ischemic stroke in pregnancy include hypertensive disorders of pregnancy, which is the #1 risk factor, but the majority of these actually happen without this. Other risk factors include cesarean, infection, prothrombotic states, AVMs and aneurysms, cardiac disease, especially valve disease because of the embolic risk, cardiomyopathies, and then high order parity. CT is your main study for these. And then initial care is, again, that stabilization of blood sugar because the brain is sugar dependent. It cannot use ketones or any other form of energy. And you want to treat any elevations in ICP. There's really minimal risk to a fetus during the ischemic stroke event unless there is hemodynamic instability. You want to maintain blood pressure at the high end of normal or high end of what we're kind of used to, because we want to keep that in that kind of that 160-ish range, because there's a sweet spot, the Goldilocks problem, not too high, not too low. Because if it's too low, we get secondary watershed. If it's too high, you get increasing bleeding. So you want to keep that a little higher than you're used to. There's no data on RTPA in pregnancy. Most of it comes out of the VTE data, but it seems to be equal risks of hemorrhage to non-pregnant people when used in pregnancy. Anticoagulation is not helpful in the acute phase in pregnant people any different than it is in non-pregnant people, so defer to your neurosurgical team. And when you put all that together, this is a schema that I made related to stroke evaluation in pregnant people, and it goes through the blood pressure control and divides out hemorrhagic versus ischemic events. And you can go through that and use that to if you are ever involved in one of these. Just a brief thought on imaging. Again, CT is going to be your frontline event. I'm highly sensitive for blood in large masses, usually readily available, and should be your first thing that you do. It is a very, very low amount of fetal radiation when you're imaging the head and neck. Similarly, the MRI, which is zero radiation, can be a little bit more difficult to get, but does give better imaging of some structures and conditions, and so should be used if needed. ACOG says that we should be using radiology procedures as needed, and I am sure that your society says something very similar. The American College of Radiology also says that we should proceed with imaging as needed for pregnant people in align with what their disease states are. All right, so let's talk briefly about seizure. So a patient walks in and has a seizure. Our first question is going to be, do they have a seizure disorder? And our second question is going to be, could this be preeclampsia? If it's not one or two, then we're going to think about all the things that can irritate the meninges in the head, as well as drug intoxication, metabolic disorders, and neurodegenerative diseases. We're going to stabilize that patient with airway, breathing, benzos, blood assessments, circulation, and we're going to try to do a good neuro exam. Looking at the baby is not our first priority. Our first priority is stabilization of the pregnant person having a seizure. This is a seizure approach in pregnancy algorithm that I also made, and it basically goes through the first 4 to 5 minutes of a seizure and the seizure evaluation. The idea being that every obstetrician should be able to handle the first 3 to 5 minutes of a seizure because we are going to see seizures. It is one of our most common neurologic events. And if your seizure continues longer than 2 minutes, it's probably not eclampsia, and you should be thinking about a benzo. And the weight-based therapy for that is about 4 milligrams of lorazepam at 4 minutes. So if you've gotten to there, think about 4 and 4. That's the easy way to remember that. This is the full status epilepticus algorithm that's published by the American Epilepsy Society. You can see it gets up to 60 minutes of status epilepticus management. Obviously, that's when you should be having a large team involved if you're getting to 60 minutes of a seizure. When you're thinking about magnesium versus other anti-epileptics, magnesium remains the mainstay of therapy, although other therapies have been shown to reduce the risk of eclampsia in patients with preeclampsia. Benzos and phenytoin really only in the setting of anti-epileptic treatment, or when you can't use magnesium because of things like myasthenia or severe hypocalcemia or cardiac ischemia. All right, I'm just going to briefly talk about paralysis. So if you have a postpartum patient who's had a neuraxial procedure, this patient in this case has got weakness in one leg with incontinence. You want to think about epidural abscess and hematomas. Risk factors are going to include neuraxial procedures, and HELP and anticoagulation are two of those things that are going to increase the risk. You can get spinal pain and point tenderness with radiating root pain, and later findings include sensory sensation losses, bowel and bladder function loss, and severe spinal pain. If there's infection, you get meningeal signs as well. The reason I'm bringing this up, although it's rare, is that if these patients have paralysis with an abscess for more than 12 hours, they will not return in function. And if they have a hematoma for more than 8 hours, that function loss will be permanent. So these are patients that you want to act on quickly, and you want to involve neurosurgery and get people involved. So in summary, neurologic disease in pregnancy should be treated similarly to non-pregnant adults. Imaging and evaluation should be completed promptly. CT scans are safe and readily available. And please ask the question, what would you do if this patient was not pregnant? Time is brain. Think about the brain approach to care. And pregnancy complications may be increased, but in general, neurologic stabilization is more important than fetal evaluation for the dyad outcome. And follow-up and aftercare support for all of these patients is going to need physical and neurologic follow-up and care. Thank you so much for inviting me to be part of your day and your course, and I look forward to hopefully being able to receive your questions, at least by email or another way, or hopefully my fellow panelists will be able to answer them. Thank you again.